Thank you everybody for coming, and I could say that I requested uncomfortable chairs because that's good for my business. So yeah, I'm surprised so many people came out on a cold night. So before I get into the topic of back pain, I just want to introduce myself a little bit. And probably many people in the audience have experienced back pain. It's second to the common cold as far as the most common reason a person would visit a doctor in the United States. So it's an extremely common problem. And so there's multiple medical providers that are involved in back pain treatment. And my specialty happens to be physiatry, which some people may have heard of and some people may not. It's a smaller specialty in medicine, but the focus of physiatry is really on the function of an individual, despite whatever ails them. And so in the back pain world, physiatrists are focused on improving the function of people with back pain, if not able to cure the back pain. Now, I did my physiatry training, or PM&R training, at Stanford University. Prior to that, I'd grown up in the Midwest and had completed most of my education in the Midwest. And I did go back to the Midwest and worked at Michigan for about 6 years for my first job. And while at Michigan, I worked in a spine center at the University of Michigan and was promoted or recruited to come back to Stanford about 4 years ago. So I've been at Stanford now for the past 4 years and work at the Stanford Spine Center, where I see patients with spine problems 4 days a week. On the fifth day, I'm working primarily on my research. And my research is mostly with the Stanford Activity Group. And I lead the group, or a group of people that's very interested in improving the way we can analyze the problem of back pain and other musculoskeletal problems, actually, and therefore produce better outcomes and create better results. And we'll talk a little bit about that later on. So here's the web page for Stanford PM&R. If you want to learn more about what we're doing at Stanford, my profile's on the website, and the profile of several of my colleagues and those that I work with in the PM&R department are here. So before I get into the introduction of what I'm going to talk about, I just want to qualify this talk. Back pain is a highly individual problem, and there's all sorts of different reasons a person can have back pain. And there's no way I can talk to a group of medical students for an hour and even describe a small amount of back pain, let alone a lay group or audience who doesn't have all of the basic anatomy knowledge that a medical student group would. So I'm going to talk mostly in generalities. I'll talk about some truths and some myths about back pain. I'll talk about some of the problems and challenges with diagnosing back pain. And then we'll talk about risk factors for back pain, and then some things that people can do. So this cartoon, if you can't read it from the back, it says, "Almost everything I have hurts, and what doesn't hurt doesn't work." And so my goal today is to help people understand that we don't have to become like that. So let's talk about some myths. What are some common back pain myths? Well, there's a couple I wanted to put in here, but I didn't have room for all of them, so I'll go through ones that I thought are the most important. One of them is that we're often told that bed rest is a good thing for back pain. And in fact, 20 years ago or so, up until that time, it was one of the more common treatments for back pain, until it was proven that it's actually harmful, that people's back pain recovers less quickly, and they have more recurrences of back pain if they're recommended bed rest. And in fact, when they did a study of that, people were smart enough to figure that out on their own. And if a doctor told somebody they should stay in bed for 7 days for their back pain, almost nobody did it. They would leave bed before that. So, people were smarter than we were at that time, and now we know for sure it's bad advice. Here's another one: only lift with good posture. Now, it's important to use biomechanics and lift with things close to your body, or not lift something heavy while twisting. But again, research is very informative here. We found that if people lift something in a way that's most comfortable to them, they're less likely to harm themselves than if they try to do it in a way that we're instructing them to do it. So what feels natural to you is probably better for you. Here's a good one. This is one I hear all the time. Disc degeneration is a disease. In fact, it's in the medical coding book as a disease, degenerative disc disease. Well, degenerative disc disease is not a disease. It's simply a fact of life. You never go to a doctor and the doctor says to you, sir, you have degenerative hair disease, or you have degenerative skin disease because I see wrinkles. You know, that's not something you're ever told. It's a natural part of life. We all accept on the exterior that things change in time. Well, that same process happens on the insides of our bodies, and discs degenerate as a part of natural aging. And if you show me a person who's 60 years old without degenerative disc disease, then I guess we'll find the first person who's lying about being older than they actually are. Here's another myth. More severe back pain means a more serious injury. And this is just simply not true. The severity of the pain and the amount of affliction is not correlated to the severity of the injury or the amount of injury that we see when we study the spine. And that's a curious thing, and we don't really know why that is. Slipped or herniated disc requires surgery. Now, while this is true, some of the time it's only true around 10 to 20% of the time. The fact is, 80% of people or more can get better from a slipped disc with treatment that doesn't involve surgery. And the outcomes in the long term for those people are just as good as the people that had treatment with surgery. Now, it's not to say surgery is bad in certain circumstances, but it's certainly not necessary for everyone. Now, some people are scared into thinking that a bad back can cause paralysis, either from a bad story they were told by someone or by an unscrupulous medical provider who wants to convince someone into a certain style of treatment. And the fact of the matter here is that the vast majority of back problems have absolutely no ability to cause any serious medical harm outside of the suffering caused by pain. And that's a hard thing to wrap your mind around, because sometimes back problems can be so painful it seems like there must be something serious and ominous. But it's been shown that really less than 1% of people who have a back problem will suffer it because of some serious medical condition, such as a cancer or a nerve injury or something that could be a permanently disabling condition. For the rest of the 99% of other people with back problems, the issue is really the back pain and not some other serious medical condition, and certainly not paralysis. And then here's one of the most commonly held myths. It's that an MRI will help the doctor and the patient with back pain. And I said the doctor and the patient because the reality is, the majority of the time, it doesn't help either. An MRI is useful in helping a doctor do something invasive for somebody's back problem. So if there's going to be a needle placed into the spine, or if there's going to be a surgery completed on the spine, then the MRI can be beneficial. But pretty much in all other circumstances, the MRI is completely useless for the doctor. And most of the reason the doctor would want an MRI is just to make themselves comfortable, to ensure that they haven't missed that less than 1% of things that might be a little more ominous. And there's better ways of teasing that out than with an MRI. For the patient, it's actually been shown that getting an MRI doesn't improve outcome. In fact, it makes outcomes worse. So people who get MRIs in general, do less well than people that don't. Now, there's a bit of a selection bias in that, because you would think that people with a more severe problem might be more likely to get an MRI. But if you control for that and you take people who have the similar types of complaints and similar severity of problems, and you compare those with MRIs to those without, the people with the MRIs still do worse. And the reason behind it, we found, is that the MRI scares people because they find out they have degenerative disc disease, right? And that's something to worry about, and it's not. So what are some back pain facts? Well, I mentioned at the beginning that back pain is common, and at least 8 in 10 Americans will have an episode, at least one episode, if not more, of severe back pain during their lifetime. So it's a very common problem. For some of those people, it becomes a persisting problem, and that can be quite troubling. But the fact of the matter is that most people with back pain get better, or have long intervals of feeling better with occasional episodes. And exercise is good for back pain. It doesn't do well to lay in bed, but it also doesn't do well to avoid activity and exercise, because in the long term, that's much better. Now here's one. Back pain often gets better with age, not worse. Now that's not everybody's experience. Certainly there's outliers, and there may be some outliers in the audience here. But the truth is the most severe back pain tends to happen in people's 30s, 40s, and 50s. And people that have persisting pain, it tends to improve somewhat over time. Now, the severity of pain is not equal to the incidence of pain. So there's more, the older a person is, the more likely they are to have back pain, okay? So the likelihood of back pain is proportional to your age, but the severity of pain tends to reduce as people age. So the message there is that if you're troubled by your back, just wait, things are likely to get better. It's like the weather in Seattle, right? We mentioned this before, and we were talking about slip disc, but this is true of almost every back problem. The vast majority of back problems do not qualify for surgery. In fact, back surgery has gotten a pretty bad rap in the press over the past 5 or 10 years, and probably rightfully so for some of the misuses that have happened. But you can't throw the baby out with the bathwater. There's certain things that back surgery does extraordinarily well. For instance, a significant deformity of the spine or a fracture and a major deformity, those can only really be corrected through advanced surgical techniques that fortunately we have these days. And then injury to nerves and those rare instances where there is a true risk of paralysis. Those are things that surgery can treat and do so very successfully. So while there is a need for surgery, it's a minority of people that need back surgery. If you take all of the patients at Stanford University Health System with back problems, it's a very small percentage of those patients that wind up with any kind of surgery. Even in a system like Stanford where the doctors communicate well and there's a good referral network, we understand that it's a very small number of patients that need to have any back surgery. And here's a troublesome one for you guys. It was troublesome for me when I first started getting into this, but I've learned to deal with it. In fact, I take it as a challenge to try to make the world better, but the source of back pain is often unknown. So why is it so difficult then to diagnose back pain? Why do we often not know why somebody's back hurts? Well, there's lots of excuses that I can give, and here's a few of them. There's multiple possible sources. Let's forget about the back for a minute and talk about knee pain. Somebody's knee hurts. Sometimes it's challenging to figure out why a person's knee hurts. And the knee is a single joint. It moves in two directions. It swings forward, it swings backward. And there's a handful of ligaments in the knee, and there's a handful of muscles that act upon the knee. Okay? But not too uncommon for doctors to have a challenge in figuring out exactly what's wrong with somebody's knee when they have knee pain. And there's obvious sources of knee pain as well, but that's a single joint. Now multiply that by a system, and if you just talk about the lower back where there's 6 discs, there's 12 what we call facet joints, which are similar to the knee joint in their structure. There's 2 sacroiliac joints. There's a greater number of muscles acting on the spine and a much larger number of ligaments. There's nerves within the spine itself and surrounding the spine to a much greater degree than around the knee. And there you can start to see some of the complexities. So if something as simple as the knee can be a diagnostic challenge, then you can understand why the spine would be more complex. The second problem, which is common to knees or anything musculoskeletal in the back, is that we have what you call soft outcomes. So in medical research, the best way to determine if option A is better than option B is if there's something that happens that you can measure and determine that, oh, A seems to do better compared to this than B. And hard outcomes are things that are very objective, like a blood test that gives you a number. And you can measure that number, and a small improvement in the number versus another is easy to measure, and it's objective and it's quantifiable. Or for bad things like cardiac disease and cancer, death is a very good outcome measure. When people die, that's bad, and you can't be halfway dead. You're either dead or you're not. So that's a very good measure. But for back pain, there's no real simple measure. Pain can be an outcome measure, But pain is a very subjective thing. Each person's pain is different. And one person's 9 out of 10 pain might not be another person's 9 out of 10 pain. And then the second problem that people with back pain have is limitations in their activities. And while it seems like it would be simple to measure activities, until recently we haven't had any really good way to do it except to ask people, what kind of things do you have a hard time doing? But everybody would give different answers based on their different life experiences and circumstances, and so it's hard to compare group A to group B with those measures of being pain and activity. And then the last thing is that there's a multitude of competing theories about why people's backs hurt. You can go to 5 different doctors like me that specialize in back pain, and you'll probably get 4 different answers about why your back hurts. All right? And then you throw in the mix a massage therapist, a chiropractor, a surgeon, your best friend, and your mother-in-law, then all of a sudden you can understand how there's a lot of mixed messages and confusion. So let's talk a little bit about some of this dilemma just within the medical world. And I call it diagnosis secrets because this, I think people generally have an understanding that doctors probably think about back pain different than chiropractors. And not that one has a monopoly on the best treatment for back pain because each brings something to the table. But they have a different framework from which they work in and trying to help with back pain. But just within the medical world, with medical doctors, there's really 3 different schools of thought about back pain. And depending on what kind of doctor you see and what their training is like and what their biases are, you'll get attitudes that fit within one of these 3 sort of categories. So the first one I call the avoidant diagnosis. And this one is predominantly promoted through the primary care community. And there's some value in this, this approach. And it essentially states what should be obvious by now from my talk, and that's that we oftentimes don't know what causes back pain. So the push from this group is for doctors to tell people when they come in with back pain is to tell them, well, your diagnosis is that you have back pain. And the patients say, well, I know I have back pain. Why do I have back pain? And then we say, we don't know. You have back pain and we don't know. And so it's called non-specific low back pain, and that's what we call the condition of back pain. So because not everybody's happy with that approach, there's an algorithmic type of diagnosis, which tends to be the type that's performed through pain centers and some surgical centers. And that's where multiple procedures are done to try to hone the diagnosis down to a specific tissue. And if a specific tissue can be found to be at blame, then a specific treatment can be rendered. And that's a very attractive option because it's nice to have an explanation of why the back hurts. The problem is, through this algorithmic approach, even when the algorithm says that the disc is the problem, and it's not just the disc in general, but that one specific disc is the problem, the likelihood of treating it successfully is 50% or less. So even with this approach, there's major drawbacks. And there's certainly some successes too. So there's value in this approach as well. And the third approach is sort of a biomechanical approach. This is more of a physical medicine, rehab, physiatry, and surgical approach. And this sort of looks at the patient as a whole and says, what things in the way the person's limbs are structured is impacting the way their back feels, what things about their lifestyle and the way they're approaching their daily lives is contributing to their back, and what things can they change in order to modify the risk. And we may not cure this person's back pain, but at least we can make them live better with the back pain. And there's utility to that approach as well. And here again, nobody has a monopoly on the right answer because different approaches probably work better for different people. But I was interested in this sort of avoidant diagnosis and nonspecific low back pain approach. And so we did a study, this is while I was at the University of Michigan, and we asked patients who came into the spine clinic at the University of Michigan when they came in for their first visit before they ever got to see me or one of the other doctors. And we asked them to rate on this scale down here at the bottom from 0 being not important to 4 being extremely important. We asked them to rate the importance of several different things. How important is it for you to get pain relief? How important is it for you to have a good and thorough physical exam from the doctor? How important is it for you to get exercise instructions? How important is it for you to get an explanation of what's causing your back pain? And on and on and on. We ask probably about 50 questions about importance and let people rank the importance of those things on this scale. And more than anything else in that whole questionnaire, patients said that getting an explanation of their back pain was the most important reason that they were there to see the doctor. And what's interesting about that is that when we ask the doctors, what do you think is important to the patients, and we want you to rate these same questions, doctors weren't very good about figuring out what patients really wanted, which is a little bit disappointing. But certainly around this thing about an explanation, there seems to be a big mismatch between what doctors are trying to do and what patients are expecting when they come into the clinics. And that's why I'm kind of spending some time in this group talking about some of the difficulties with making a diagnosis, because I think that leads to some of the confusion. So as far as biomechanics go, I spent just a moment talking about some of the problems with an avoidant approach. The biomechanical approach, I think, has some benefits, and it's based not just on an attitude about how the person is, but it's also based on some truths at the tissue level. And this graph represents a study where they looked at pressures from low to high inside the discs of the lumbar spine as people assume different postures. So as you're lying on your back, you have the lowest pressure in your disc. As you turn to your side, it increases a little bit. As you stand up and put more weight on top of your spine, the pressure in the discs increases even more. When you bend forward, that flexing the spine causes more pressure on the side of the spine where the discs lie. And if you sit, because of the change in your posture, it increases the pressure relative to standing, and then bending with sitting increases pressure even more. And so it's long, this graph you can see here is listed from 1999. The study actually was done a few decades earlier than that. And so since that time, it's been fairly well accepted or assumed that prolonged sitting might be bad for discs. And this, I'll be the first to admit, this joke's probably not very funny because it's sort of an inside joke. But back in the late 90s, when I was doing my residency training and fellowship at Stanford, it was the middle of the tech boom. And flooding into the spine clinic were all these computer programmers who would sit for 14 hours a day, 6 or 7 days a week, and then they would take an hour off to come into the clinic and find out why their backs hurt. And so we called that floppy disk syndrome, because it's a pun on computer floppy disks, which don't exist anymore, and having a painful disc. But sitting for a long time isn't bad just because it puts pressure on the discs. The discs are built to withstand pressure. I mean, for 2 million years we evolved as hunter-gatherers, and to be a hunter-gatherer, you got to stress your disc in your body. You got to catch an animal. You got to pick the berries and the nuts. And so the spine isn't a delicate structure. It's built to last and do the things that we need to do. It's built to be used. But what it's not built to do is just to sit still all day. And the problem with that is, again, based on our knowledge of physics and anatomy. The disc, if you consider this as a cross-section of the disc and the lower back, it's the largest structure in every adult human's body that doesn't have a blood supply. There's no other tissue in the body as big as this that doesn't have blood vessels inside of it. And so the only way it gets nutrients in and waste out is through diffusion. And that diffusion happens through the bone adjacent to the disc. So there's blood vessels in the bone, and those blood vessels send nutrients down and transport the waste out. And that process is aided by pressure coming and going, okay, by a pumping action. And so if you sit all day and just have a resting kind of increased pressure in your disc, you're pushing things out, but you're not letting things in. And so that's why prolonged sitting is bad, and it's probably one of the reasons why exercise is good. But the biomechanics are more important than that. The discs and the joints and the ligaments of the spine only provide about 60 to 70% of the structural stability of the spine. In other words, if all you had were the joints and the ligaments of your spine would collapse under its own weight. It needs the muscular support, the cylinder of muscles that surrounds the spine, to provide additional support for the spine to make it function well. it's like a Pringles can. You ever try to collapse a Pringles can or twist it? It's a pretty strong structure because cylinders are strong. They're used in construction and engineering and all sorts of things because cylinders are strong things. And so the muscular cylinder that is our core is a very important part of a healthy spine. But back pain is not only biomechanics. There are several other factors involved. And this cartoon here says, you got to be kidding. Your back still hurts? And he has about 1,000 acupuncture needles stuck in. So what are some risk factors? Well, smoking is consistently shown as a risk factor for back pain. And the reason we think that is that nutrient transport from those small blood vessels in the bone into the discs of the spine, that's interrupted by smoking. Smoking causes problems with your small blood vessels. And those small blood vessels are affected like others, and there's consequences. Night shift work is a problem for the back. Interesting, huh? And that comes down probably again to that same biomedical process I mentioned. People who work night shift tend to sleep in strange ways, right? They'll sleep 3 or 4 hours one part of the day and another 2 or 3 hours another part of the day, but they don't tend to have that prolonged length of time in bed at night. And when you're lying, you have a very healthy pressure in your disc, and it allows for a lot of diffusion in to the disc from the bones. And that's different than the pumping action you get during the day. And research on disc is beginning to show that those two scenarios are healthy for the cells, that they like that change that occurs through activity during the day and then that prolonged change that happens by recumbency at night. Hard physical labor. So I'm not talking about your average sort of labor job, your average carpenter. I'm talking about lifting heavy boxes, operating a heavy jackhammer. Hard physical labor is a risk factor for back pain. Sedentary lifestyle is a risk factor for back pain. Sounding like a broken record when I'm talking about exercise? Well, I'm not done with you guys yet. And obesity, very clearly associated with back pain. Now, many people who aren't obese have back problems, but the risk of back pain increases with weight, and it increases in step with the amount of weight that a person puts on. So what can you do about it? Well, this doctor says, your x-ray shows a broken rib, but we fixed it with Photoshop. All right, well, remember those risk factors? So here I say, don't smoke during your scheduled breaks from your night shift job loading boxes for UPS. All right, that's the first thing you can do. But if you don't work for UPS, and you don't work the night shift, and you don't smoke, these are the two lifestyle things that you have control over, that you can do, or that you can recommend to those you know that might help their back problem. And even if you don't have a back problem, that help reduce the risk of developing a back problem over your lifetime. So obesity is a tricky issue, and we know obesity is linked to activity. But the curious thing about that is we don't know the chicken or the egg. Are people obese because they're not active, or are people inactive because they're obese? Interesting, right? We don't know. So I'm not going to talk about obesity so much. I'm going to talk more about exercise. When I first got interested in researching about activity for back pain and exercise, I had a good idea. I thought, well, let me go to the PDR. It's the ultimate reference for medicines. And exercise, in essence, is a medicine. In fact, there's a whole group of physicians that have developed an organization surrounding exercise as medicine. It's called Exercise is Medicine. You can Google it. So I entered exercise into the PDR to see what kind of medicine exercise is, and the PDR found 0 results for exercise. So according to the PDR, exercise is not medicine, but I'm telling you it is. So first of all, we should talk a little bit about what exercise is, because I bet a lot of people out there are assuming something that I don't mean when I say exercise. And then I'm going to talk a little bit about how it helps, and then we'll talk for a few minutes about why people avoid taking their medicine. So what is exercise? Well, exercise, the actual definition is it's a physical activity for the purpose of fitness or of health benefit. And the nerdy answer, and since I'm a Stanford professor, I'm by default a nerd, the quantified answer is that exercise is the use of oxygen. And the way we measure oxygen consumption in the human body is by what's called metabolic equivalence. And oxygen is one of the fuels for the cells of the body. So the amount of work being done at a cellular level can be measured by oxygen consumption. And that can be done in the laboratory. You can actually very precisely measure the amount of oxygen somebody's consuming. If you put them in a bubble where no gases are let in or out, and you can measure what's happening inside. And so 1 MET, or metabolic equivalent, 1 MET is equal to the oxygen that we tend to use when sitting quietly. That's 1 MET. So physical activity is measured in METs, and it's separated into these 3 primary areas of intensity based on these different thresholds. So less than 3 METs is considered light. Between 3 to 6 METs is considered moderate activity, and greater than 6 METs is considered vigorous activity. Exercise can be considered anything that's moderate or vigorous, okay? So anything in the moderate activity range is exercise because you get health benefits from it. And what are those things? Well, here are things that are less than 3 METs: sleeping, watching TV, writing, desk work, typing, walking at a slow speed, or walking at a moderate speed. Moderate intensity activities, so now the things that give you some benefits for your health, are stationary biking, walking at 3 miles per hour. So that's a little faster than the average comfortable walking speed. Most people walk around this 2.5 miles per hour, 2 to 2.5 miles per hour. So a slightly faster walk is exercise. Home exercises, light calisthenics, cycling, even just leisure cycling. And these kind of light activities are true exercise, and they're things that you can get benefits from. And then the greater intensity of the exercise, the more benefits you'll derive from it. So vigorous activities like jogging, playing sports, jumping a rope, these things all will have greater benefits, but you don't have to do things that vigorous in order to be getting exercise. And what do you get for your efforts? Well, it doesn't just help your back. There's a lot of good things that come out of exercise. And this graph is a nice kind of overall representation of all the benefits of exercise. So over here on the left-hand side, if you go higher on this side of the graph, you're increasing your risk for things. If you go lower on this side of the graph, then you reduce your risk for things. And if you go further out this end of the graph, you need to exercise more to achieve those benefits, okay? So you can see the black line is all causes of mortality. And the more you exercise, the lower your risk of mortality and the longer you're expected to live. And see that benefit is huge here for the first hour and a half per week of exercise. But you continue to get benefits all the way out to here, and it keeps going down, and we don't know where it stops going down. So, you can exercise as much as you want, but at least an hour and a half to get major health benefits. And then you can see the risk of diabetes is reduced, hip fractures, cardiovascular disease, depression, cancer risk is reduced by exercise, and back pain. So we started looking here at Stanford at the benefits of activity for back pain, and we decided to try to quantify it better than what we've done in the past. So instead of asking people how active they are, we put monitors on them so we could actually measure their activity on a day-to-day basis. And by quantifying it more, we're able to find out a lot more about the importance of physical activity. And we used the results from this survey of about 7,000 patients, and we're able to show that 1 hour per day of moderate activity, so that could be walking at a slightly increased pace, doing some sort of light calisthenics, riding your bike around the neighborhood or to work, an hour a day of those kind of activities reduce the risk of back pain by half, all right? And furthermore, those benefits were even more pronounced in people who are overweight. So while it helps everybody, for the overweight people, activity seemed to be even more protective from back pain. And nobody ever knew these things before. And so we're actually applying these activity monitors to start to begin to study important factors related to lots of different musculoskeletal problems, and I'm pretty excited about the research. But this is the official recommendation for activity from the U.S. Department of Health and Human Services. And this is a consensus statement that came out of the 2008 guidelines. And so the graph I showed you earlier that showed the reduced risk of all mortality is a reflection of this. And that's that somewhere between 2.5 to 5 hours of moderate intensity activity per week, or 1.25 hours of vigorous activity is able to provide a person major health benefits. So if we know that exercise is good for the back, if we know it's good for so many other things, then why don't people do it? And this is where back pain, again, becomes very interesting in this story. And that's because it can be hard to exercise when your back hurts, and especially if exercise is making your back hurt worse. So pain is a major limiting factor for people who want to exercise but don't. And this probably, almost as much as anything else on this list, might be a reason to seek the assistance of a physician or a chiropractor or whatever provider it is that you have found can help you with your back problem in order to get you to the point where you can exercise more when back pain is the limiting factor. Because if you can get through that initial part of ramping up into exercise, the benefits quickly come on, and then you can sort of keep going on autopilot. But people give excuses because of time, or they never exercise, they don't know what to do. Depression is, it takes the wind out of people, and they just don't exercise. But fear of injury is another interesting thing that keeps people from exercising. And there's some pretty good research on back pain that shows that people who are fearful of injuring themselves for their back actually do worse over the long run than similar people who are willing to give things a go. So a big part of my job is often allaying people's fears about what to expect and what they can do, and allowing them to be more active. And I see them frequently do better as a result. So in conclusion, this cartoon says, I don't need that exercise stuff. I cross the pain threshold just getting out of bed in the morning. And hopefully you can see that I think that I don't want anybody to feel like this, and I don't think anybody needs to feel like this. There's ways of getting around it and ways to exercise. Back pain is a complex problem. There are many different types of back pain and causes of back pain, but some of the generalities we talked about today are pretty much helpful across the board. And I wanted to leave some time for questions and answers because I know people have a lot of questions. So I'm happy for people to stand up and ask questions if they want. Yes?
This is part A and part B about sitting. If you're going to do moderate exercise and you have available a recumbent bike or a treadmill, is there anything wrong with using the recumbent bike? That's A. And B is if you have a desk that allows you to raise it or lower it for standing or sitting, what's the ratio of standing and sitting you should do per hour?
Okay, so good question. So two-part question. First question is, if you have a treadmill or a recumbent bike, which is better, essentially, or is there something wrong with a recumbent bike? And the answer to that is that in the end, with the exception of certain specific spine problems that I won't get into, what matters more than which type of exercise a person's doing is that they're exercising. So my number one recommendation to people about exercise is do something that's available to you and that you like, or that you hate the least, right? Because whatever you want to do is what you're going to do most frequently and most regularly, and that's going to be the most beneficial for you. Some people, however, have a problem with maintaining certain postures, or quickly get into problems even by any posture as long as they're in it for a while. So I'll often recommend to some people to try to find an environment where they have a sitting exercise piece of equipment like a recumbent bike and a treadmill nearby so they can switch back and forth as the need arises. Part two of the question is about sitting and standing desk. And There's no hard and fast answers to that, except that a general rule of thumb is that if you're sitting for an hour, you should take at least a 5-minute break to get up and move around. Otherwise, it's just listening to your body, and if it's telling you to stand, stand and work. When you start to feel like sitting, then sit and work. Yes?
I've read that sometimes subluxations are identified as cause of back pain by chiropractors. And I'm wondering, in conventional medical practice, is there really considered such a thing as a subluxation? And what is it, if there is?
Yeah, so the question is about chiropractic diagnosis of subluxation and whether medical providers like me make that diagnosis, and if so, what does it mean? So there is a segment of medical doctors who practice what we would call, and specifically osteopathic doctors who practice a type of manual therapy that diagnose subluxations in the spine. They don't tend to call it that same thing, but it's a similar type of diagnosis. And they use that type of diagnostic system to prescribe treatment for people. And there's even some MDs that have learned those tools and methods and use them, but it's not commonplace. When a medical doctor thinks about subluxation, we tend to think about a condition called a spondylolisthesis, which is where the vertebrae have slipped out of alignment, and you can see it radiographically. The difference between that and the chiropractic or the osteopathic diagnosis is that they make the diagnosis with their hands, sometimes with x-rays, but the medical diagnosis of a spondylolisthesis is made with radiographs always. The interesting thing about that is it looks pretty serious for a person to have a slipped vertebrae, for their vertebrae to be completely out of alignment. And it sounds dangerous, and a person with that condition might be afraid that they can't do much because they might hurt themselves, right? And in fact, nerves can get pinched as a result of that. It can be pretty painful. Well, about 1/3 of NFL football linemen have that condition in their back. Andre Agassi played his whole entire tennis career with a severe form of that condition. So even a serious problem such as a major slipped vertebrae or what we call spondylolisthesis does not have to be functionally limiting. Now, I'm sure I never treated Andre Agassi. I'm sure he had some trouble with his back and needed some help along the way, but he was a pretty darn good tennis player. So.
Does scoliosis become worse as you get older?
So the question is, does scoliosis get worse as you become older? And that's a yes or no answer. For some people it does, and other people it doesn't. The progression of it definitely, if it's an adolescent type of scoliosis, then the scoliosis tends not to progress through adulthood. It tends to stop progressing in adulthood. If it's an adult onset type of scoliosis, then it's more likely to progress. And then for women more than men, thin bones can play a big role in advancing a scoliosis. And that becomes a major factor in scoliosis getting worse later in life. Yeah, so the question is about what do I recommend for back spasms, and what advice do you give people who are kind of stuck in the trap of not exercising because of their pain, but clearly benefiting from it when they do. And so for back spasms, if it truly is a muscle spasm, usually either ice or heat can provide some temporary relief, but only temporary. It really comes down to regular exercise to try to make the muscles hurt less and function better. Some of the muscle relaxer medications can be used if, in my opinion, really only if the spasms are keeping people awake at night, because muscle relaxers are more sedatives than they are muscle relaxers. But they'll help through the night and improve sleep. And sleep is closely tied to pain. You can take normal people that have no pain, deprive them of sleep, and they'll develop muscular pains. A high percentage of them will. And so there's a close connection between good sleep and pain. And then you take somebody who's got pain already, deprive them of sleep, that amplifies the pain, which makes the sleep worse, and then there's a vicious cycle. So there's a lot of these vicious cycles that develop in the situation like you described, and it's a complex problem to treat, but you have to identify the sources feeding into those cycles and then try to interrupt them. And that requires a lot more details than I'll be able to get from you right now. Yes?
Is that the difference in the exercise you do, for instance, like using the elliptical or the treadmill or the stationary bike, does that any of them make things worse?
Generally, no. Just exercising in any form is better than not. But there are specific spine conditions where I'll sometimes recommend different forms of exercise. So for instance, spinal stenosis is a common spine problem, and it can bother people more when they're in erect postures. So a person with spinal stenosis can do a perfectly good workout on a stationary bike because they're sitting, but they're not going to do so well on a treadmill. So, yes?
Two questions. One, you talked about the floppy disk disease. That seems to me to relate also to posture. Is posture being looked at as part of a problem for creating back problems? I work in a school and I look at our young people and I'm in absolute terror of what their lives are going to be as they sit here like this at the age of 10 and they can't straighten their backs at all. And also, is there any research looking at acupuncture for back pain relief?
Good question. So the first question was about posture and what its impact is and how it's being looked at. Posture is a very important part of the biomechanical approach towards back problems. And there's several different leaders in the thought about posture and its impact. And I didn't go much into that today because it's another huge topic. But posture is not a panacea either. There's certain back problems posture would help and others that it won't. Certainly the electronic age with small mobile devices is probably making matters worse, but the Industrial Revolution was really the first step in making all of our postures worse by forcing us into postures and activities that just aren't the way our bodies evolved over 2 million years. And then the second question is about acupuncture. And acupuncture is interesting because it works by a methodology that's separate than Western medicine, but Western medicine science has shown that it is helpful for back pain. So the question is when to recommend kyphoplasty or vertebroplasty. And just as a bit of background, these are procedures that inject bone cement into fractured vertebrae. And for people that have had compression fractures, they'll know that they can be quite painful. The majority of them do improve in the several weeks, but there's certain fractures that can continue to be painful. I would say my trend is pretty much the same as the general trend. I used to recommend them quite a bit more 5 and 10 years ago than I do now. And that's predominantly based on emerging research, which shows it doesn't do much to change people's symptoms in the medium and long term. So, question there in the purple scarf?
Yes. It's a 3-part question. Number 1 is personalities involved in back pain. Is genetics involved in back pain? And is weather?
Aha. All right. Wow. No softball questions here tonight. Weather's clearly involved in a lot of degenerative pain processes. I've never heard a convincing explanation of why that occurs, but it's clearly a pattern that happens. And it's something that some smart researchers should really start to figure out because it probably teaches something about the mechanisms of pain. I didn't get into this at all in the lecture tonight. I wanted to talk about it a little bit too, and since you gave me the opportunity, I'll touch on it. And that is, one of the difficulties with diagnosing where something hurts in somebody's back is that the amount of changes or degeneration or injury that we see doesn't really correspond with where the pain is or the amount of pain. And in fact, you can take 2 people's spines that look exactly the same on an MRI, and one person be terribly afflicted by pain and disability, and another person say they have no back problem whatsoever and never have. But this whole weather thing probably is associated with some sort of pain mechanism that we don't understand. Personality plays a pretty big role because some people are overachievers and they do too much, and some people are the opposite. Some people are glass half empty, which is a bad way to look at the world, especially when your back hurts. So that plays a role, and certainly it's part of the individualized care that a person needs to help them with their back pain or any other medical problem for that matter. And then there was a third one, genetics. Yes, genetics is important in 2 ways. Anything that happens to humans has a genetic underpinning to some extent or another. And pain perception is partly genetic. So one person is very unaffected by pretty significant experimental induced pain, while another person might be bothered by a very minor amount of it, and that's partly a genetic thing. And also the likelihood of developing degeneration in these tissues, just like some people's hair gets gray faster than others, that's partly genetic. Some people's discs degenerate faster than others because it's partly genetic. The first comment was about, or question was about swimming and whether or not that's a good option. And again, any kind of exercise that you can tolerate is better than none. And many people that have pain with weight bearing will do much better exercising in water than they will on land. And so a lot of people find that they can get a good exercise, good regular exercise in the water that they can't get otherwise. So I frequently would recommend that to people. The second part of the question is about laser surgery. And I'm going to try to be diplomatic. Lasers have no real proven use in the spine. It's not that lasers can't be used, but they're used to do things that we do better with other tools. And there's a lot of advertising for laser surgery in magazines and other things, and it's mostly promotional. The majority of those surgeries have nothing to do with lasers, and the laser gets used a minor amount, and it's mostly a promotional tool. But the surgery that happens are the same techniques that we know are helpful, so I wouldn't expect any different outcome than what I would expect from the same type of surgery that didn't use a laser. So what other exercises can somebody with spinal stenosis do that's not a treadmill and not an exercise bike? Swimming, again, is often well tolerated because it allows postures that are less bothersome. And then if a person with spinal stenosis wants to use a treadmill, they can use a treadmill as long as they have handholds and can lean forward quite a bit, then that allows a good walk without the same aggravation that they would get from walking outside or on the treadmill normally. The first part of the question was about stretching. We talked about exercise as far as fitness type of exercise, but not other forms of exercise. So cardiac fitness exercise is known to produce more benefits than stretching, even for back pain. So that's why I focus mainly on that. But when I prescribe exercise and certain physical treatments for people's back problems, there's almost always a stretching component that's involved. And which stretches are most important depend on what the underlying problem is. Because certain conditions would want a person to stretch one way, whereas other conditions would do better by stretching in another. And then the second part of the question was about the sitting on the exercise ball. And the thing about sitting on an exercise ball is it forces a person to sit with good posture. And usually that change in posture changes the force dynamics through the lower part of the back and relieves some stress on certain parts of the back. So people that have certain back problems, that's one of the things that we often recommend is that they find a different way to sit. And using an exercise ball forces people to sit in a certain way, which can be beneficial for certain back problems. In the green shirt?
Give a recommendation for a means to measure when you're exercising too much, making your back pain worse.
Yeah, it's called your pain. So if your pain's telling you, but here, yeah, the bottom line is this. For a person that's had chronic back pain, and by that I mean, pain that's lasted for more than a year, it's a lifestyle choice more than a medical choice or an injury choice. Because we've done the studies where we looked at people's MRIs before they had back pain and after they started having back pain. And there's no tissue injury we can observe at all. So at a gross level, anatomically, there's nothing dangerous or bad happening. So, for somebody like Andre Agassi, I'm certain he had back pain when he was playing tennis. I'm certain he aggravated his back in doing it. But the reward was much greater than the pain. And that's a choice that people are free to make. And so there is none. And the purple shirt?
What is the difference between a slipped disc and slipped vertebrae? with regard to considering spinal fusion?
A slipped disc almost never requires a fusion. That's what we would call in the medical world a herniated disc. Slipped vertebrae is where the vertebrae are out of alignment, and there's debate about when that needs a fusion and when it doesn't. Sometimes it clearly does, but there's often times where it's not certain if it does or not.
Is that what they term instability?
Yes. It's called instability. Yes, up here.
Is there a pain clinic that, if somebody has chronic pain and exercise is not enough, in terms of looking at options?
At Stanford, is there a pain clinic or in general?
Wherever in the Bay, in this area.
Yeah, so there's several pain clinics in the Bay Area. Stanford has a pain center. There's a pain center down in Los Gatos. There's several that are focused more on the workman's compensation pain system. Unfortunately, because of the way that our healthcare environment is broken, the best treatment for back pain, the best comprehensive treatment for back pain is reserved for injured workers. And it's not available to the general population in most places. When I was practicing at the University of Michigan, it's a state hospital, and it believed it had a duty to the people of the state to provide those services. So we actually had a very good comprehensive pain program at the University of Michigan that was available to all people. But there's very few places where that exists. But there's some hope. The Obamacare, if you will, the law is written in such a way that's going to promote the proper use of medical resources and will probably make things like that much more available to the wide population. So, yes?
I had an MRI, and my doctor said that I have a ruptured disc and 2 more that are pinching the nerve. He recommends an epidural. How do you feel about that?
I give epidurals. They help. They're a means to an end frequently, but you know, there's a lot of things to consider as far as risks and benefits to determine if it's actually necessary in your case. I mean, I couldn't comment on your case in particular, but yes.
Discuss physical therapy.
Yes, physical therapy. I probably prescribe more physical therapy than I prescribe anything else to my patients, and physical therapy is helpful in a lot of ways. You know, I don't have time to teach people how to do their proper stretches. I don't always have time to go through the full exercise prescription. I can point people in the right direction and get them hooked in with the right people, see them back and make sure they're doing things, because sometimes people get, you know, misplaced or mistreated. But I find physical therapy, you know, I couldn't do my job without physical therapists. So we have time for one more question. Nobody's asked me the mattress question. I always get asked the mattress question. All right. Can't believe it. All right, so yes, which mattress is best? So it's true that a firmer mattress is probably better than a mattress that's too soft, but too firm is also uncomfortable. More important than any of that is what your body tells you. You know, if you've been to a friend's or relative's house and you slept a really good night, find out what mattress they have and how they use it and get one, you know, because your body will tell you what mattress is best. So, great. Thanks, you guys. I really enjoyed it.